And thank you, Larry. We're going to come back to some of those issues when we get to the panel discussion. I have a question or two that I want to follow up with as well. I'm sure others do. But let's move on to substance abuse, always a popular topic. So Richard Stripp, the floor is yours.
Thank you very much. I'm going to talk a little bit about substance abuse and prescription drug monitoring, as well as issues with regards to illicit drugs and so forth, particularly with the injured worker and its relationship to transportation. One thing that's probably obvious to everyone, but it's not on everyone's mind, is that the opiate crisis has not gone away. If we were having this meeting a year ago, we probably would be talking more about the opiate crisis than we would be about COVID. But obviously the pandemic has overshadowed that, but it has not gone away. In fact, the number of individuals that are abusing prescription drugs, as well as the number of individuals who are using illicit drugs and alcohol, is increasing. And that's for obvious reasons. As we heard from a previous speaker, the anxiety of being at home and the pandemic itself obviously has increased the use of things like antidepressants and so forth. But you're also seeing increases in the use of recreational drugs, as well as other prescription drugs that have high abuse potential, like opioids, fentanyl, and so forth. So basically, I want to talk a little bit about, identifying some of the issues with regards to substance abuse in the context of the pandemic. So the type of testing, basically, I kind of put it as the two buckets. We have testing that's related more to federally regulated DOT type testing, which is your typical SAMHSA testing, where you're testing for pre-employment, post-accident, reasonable suspicion, return to work, and follow-up. That's the required testing where you basically originally would have to do the NIDA 5, which was THC, cocaine, opiates, amphetamines, and PCP. They've now added to that oxycodone, hydrocodone, 6-monoacetylmorphine, which is heroin metabolite, and ecstasy. But obviously, the breadth of testing with regards to SAMHSA testing is not really adequate to capture a number of other drugs which have high abuse potential, things like fentanyl, synthetic cannabinoids, synthetic cathinones or bath salts, muscle relaxants, and the list goes on. So there are a number of drugs that basically would not be detected under those circumstances. The other kind of bucket I would talk about are the prescription drug monitoring programs that we have in place for the injured worker. And that's more of a targeted testing that would be more based on, who to test, what to test for, and when to test them. And so it's really based on a risk-based analysis where we try to contain costs while at the same time providing efficient testing. You'd probably be surprised to know that when we do targeted testing on injured workers, and when I talk about targeted testing, I'm talking about high-risk injured workers. So we define a high risk as somebody who it's based on MED levels, morphine equivalent dose. It's based upon things like polypharmacy. Are they being prescribed other drugs like benzodiazepines? Or have they had a test for an illicit drug positive in the past? So we have a number of triggers that allow us to identify the level of risk. So when we do targeted testing based upon risk in injured workers, we see greater than 70% of those patients actually show some sort of inconsistency. And an inconsistency would be described as a positive test for a prescription drug that shouldn't be there, a negative test for a prescription drug that should be there, or a test that shows the presence of an illicit drug. That's compared to about 40% when you test the entire population. So it's quite high in the injured worker. Now, we have the challenges now with the pandemic with regards to collection, right? So Now we have individuals that are remote. Collection has become an issue. It's hard to, many of the clinics are closed, so urine collection is becoming an issue. So we talk a lot about matrices with regards to the pandemic. The classic matrix that's typically used for drug testing is urine. And it's been the gold standard for drug testing for many, many decades. But other matrices are also available, like oral fluid. Now, the SAMHSA has also recently identified oral fluid as a viable matrix for doing drug testing for federal regulated testing. Oral fluid has the advantage of being a supervised collection. Urines basically have the issue of being the easiest to beat, like substitution and adulteration and things of that nature. Even under circumstances where it's an observed collection, there are a number of different ways in which creative individuals have found ways to beat the test using, various products. But the oral fluid collection is actually done with a person observing the saliva being collected. It actually lends itself quite nicely to telemedicine, which somebody's going to talk about later. But with telemedicine, we can actually do remote oral fluid collections so that we could do prescription drug monitoring. So, a lot of what we do with regards to drug testing is screening and definitive type testing, with screening being testing using immunoassay, and then definitive testing using liquid chromatography mass spectrometry. So the real challenges now with the pandemic is obviously that you're seeing an increase in potential for abuse. There's a decrease in the access to substance abuse treatment. Many of the treatment centers have had closed their door, or they're limiting access, or they're doing things remotely. So drug testing became a significant challenge. So a lot of the prescription drug monitoring and substance abuse monitoring has decreased, while the actual abusive practices have likely increased. And again, we've met some of those challenges by doing things like remote collections and so forth. But the types of drugs that are typically being found still are the classic stimulants, amphetamines, cocaine, with the number one being opiates, as well as the increase in cannabinoid use with the relaxed restrictions in many of the states and its legalization for recreational use. But alcohol still is probably at the top of the list as something that's abused. And again, with stimulants, you not only have the issue of the person potentially using a stimulant for increased performance, then you also have the crash period that follows and the washout period where the person develops hypersomnolence, and that's when you have potential issues with people falling asleep at the wheel and so forth. And certainly many of the other drugs like opioids and benzodiazepines and CNS depressants increase the likelihood of motor vehicle accidents as well. So obviously the challenge is we're seeing increases in potential abusive practices and challenges in actually getting the samples into the laboratory.
Thank you, Richard. I think that's really an important perspective to keep in mind, that that you made right at the beginning, that even though the pandemic is sort of overshadowing everything else, the undercurrent is that a lot of the problems that were already existing and severe in workers' comp, and particularly in the transportation industry, have not gone away, and in fact have gotten worse. And we'll come back around to that. It's probably a really good segue to behavioral health, which is obviously allied to a lot of the points you've made. So, Phil, I believe you're going to start us off with a discussion, and then Dave Vittoria is going to build on that.
That's right. Thank you, David. Now, Mary Kay is going to bring up some slides. Thank you, Mary Kay. I'm going to ask the audience for a moment to step outside of workers' compensation and transportation for just a couple of minutes. I want to start looking at America as a whole. The information on the slide in front of you right now came from that study that I referenced earlier, State of Mind. And I just want to point out that, mental health in this country is a very significant concern. As you can see highlighted there on the right, 1 in 5 U.S. adults, 20%, experience a mental health event each year, but only 40% of them receive treatment. Imagine for a moment how we would react if we were seeing statistics that only 40% of diabetics receive treatment. Only 40% of patients with hypertension receive treatment. And yet when it comes to mental health, this type thing goes on. And ironically, I've been a pharmacist for over 4 decades. This was of discussion when I was in pharmacy school, and it's still a significant discussion today. The pandemic has just highlighted this even more. Another point that I want to highlight here, 60% of people that have a mental health condition are undiagnosed and not getting treatment. And then carrying this back to a significant theme of today regarding insomnia, 50 to 70 million Americans endure the effects of sleep disorders. And these are huge numbers. Mary Kay, let's go on to the next slide. When we start bringing this now to the workforce, I want to focus on a couple of things on this slide. First of all, down the lower left, 24% of all costs caused by workplace accidents are associated with insomnia. That is a huge number. And we've talked about things that affect sleep and lead to this. I want to introduce one more concept. I'll never forget the first time in workers' compensation that I saw a prescription for Ritalin processed. My thought was, why on earth was Ritalin approved for a workplace injury? Well, let's trace the thought process back. And it happens over and over and over again. Injured worker is injured. Dr. Strip pointed out opioids are used so often and are such significant concern. And if that patient's experiencing pain, all too often they receive an opioid. Opioids cause many side effects, not least of which is drowsiness. Patient goes back to the prescriber complaining of drowsiness. One response would be decrease the dose of the opioid. All too often, though, what we see is let's prescribe the stimulant, which is how we start seeing Ritalin, amphetamine, Adderall, all these very powerful stimulants being prescribed for injured workers. What happens when one takes a stimulant? You can't sleep at night. So now we see the addition of drugs like Ambien, and we see this cycle recur over and over and over again, unfortunately. So a lot of the insomnia we're talking about is definitely associated with apnea and things of that nature. It's also associated with side effects of particular drugs, the stimulants. Mary Kay, let's go on to the next slide. Looking at America as a whole, what Express Scripts found following the start of the quarantine, and the chart there shows the data early January and then continuing on through May. First of all, anti-anxiety medications increased 34.1%. When we say anti-anxiety medications, we're talking about benzodiazepines, drugs like Xanax or alprazolam, Valium or diazepam, very powerful medications, addictive medications. David Victoria will be addressing these concerns in just a few moments. The use of benzodiazepines in workers' compensation, especially, should be very, very limited. I'm not saying that these drugs don't have utility in the care of certain conditions. They do. But the use of workers' compensation should be extremely limited. Post-traumatic stress disorder always comes up as a question. This is not an appropriate category of drugs to treat anxiety in those situations. Another thing that we saw was that the week ending March 15th, the use of anti-anxiety medication spiked by another 18%. and that women are at a much higher rate of men in terms of using these medications. Overall, 45% of adults in this country reported that their mental health had been negatively impacted due to worry and stress over COVID-19. Next slide, Mary Kay. So when we talk about these medications, I've discussed a couple of them in particular. Let's talk about some of the other ones. First of all, depression. The use of antidepressants has gone up significantly. Talking about a number of different medications, not going into the details of all these. We're discussing all these acronyms: selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, et cetera, et cetera. Basically, they're all being used for the same purpose, that is to treat depression. These drugs, in the strictest sense, are not considered to be addictive. And yet, at the same time, they're not a category of drugs where it is easy to get a patient off of them. I want to introduce the audience to a new term. Now, those of you involved in healthcare, I'm sure, are already familiar with this, but some others may not be. And the term is de-prescribing. That's D as in D-E, David Edward. De-prescribing or discontinuing a drug. A colleague of mine, Dr. Steve Stanos, told me years ago that in medical school, he was taught how to prescribe drugs. He was never taught how to stop drugs. He related that, he said, that's somewhat akin to teaching a pilot how to fly a plane without ever teaching him or her how to land the plane. And that struck me as being very, very profound. And ever since he said that, I've noticed this over and over again. It is easy to start a patient on drugs. It is very difficult to get patients off of certain types of drugs, especially antidepressants, and obviously the addictive drugs like benzodiazepines and opioids and things of that nature. Next category of drugs, talking about anxiety, anti-anxiety drugs, the benzodiazepines. We've discussed those. I want to add one more comment. And again, another concept that I want the audience to think about. It says the appropriate utilization of this category of drugs is as needed. As needed comes from the Latin abbreviated PRN. Now, when I was in school, I was taught that PRN actually had multiple translations. As needed, unfortunately, is the most common. Another appropriate translation is when needed. And possibly the best translation is if needed. I'm pointing this out because when you tell a patient, as the prescriber, whom the patient admires and is going to follow their advice, when you tell them, take this drug once a day as needed, they're going to take that drug once a day. Wow. Tell them to take it once a day if needed, you can see the light bulb go off. I mean, if I don't need it, I don't have to take it? Yes, that's absolutely correct. That's an appropriate way of looking at these drugs, only if needed. Last, insomnia, the sedative hypnotics. So we've talked about stimulants and how they relate to causing insomnia, and then we have drugs like Ambien, probably the most common one that we see in workers' compensation to treat insomnia. Well, when you look at a drug like Ambien, the intention is for short-term use. 3 weeks, 21 days. What are you supposed to accomplish in those 21 days? Teach that patient something that's referred to as good sleep hygiene. Help them to understand that this is not the cure. This is a way to get them to a point where they can manage their own sleep. Sleep hygiene means giving up things like stimulants. And not only prescription drugs, something as simple as caffeine. It means having a routine, many things that the patient can be taught basically to take charge of their own care. Again, de-prescribing in workers' compensation, how often do we see a drug like Ambien discontinued? Not nearly often enough. Mary Kay, let's move on to the next slide. Now, before I hand it off to David Vittoria, there's one other final concept that I want to add to this. Dr. Strip mentioned, and others have as well, prescription drug monitoring programs, an extremely powerful tool when it comes to battling the prescription drug epidemic. In those states that have mandated the use of this tool, I think the result has been even more impactful. There's one thing, though, that really concerns me, and that has been the state legalization of recreational or so-called medical marijuana. Now, regardless of where one is on the fence when it comes to legalization of marijuana, my concern is the fact that as long as this is being driven by the states and not the federal government, medical marijuana will never be treated as a prescription drug. Why? Because it's illegal at the federal level. It cannot be defined as a prescription drug by the FDA or any other entity, the DEA, anyone else. Prescription drug monitoring databases are just that. They're for prescription drugs. And with very few exceptions, Connecticut being the one that comes to mind first, most states have not addressed marijuana when it comes to creating these databases. So even though a prescriber can look and see everything that's going on in the prescription drug treatment of a patient, they're not able to see medical marijuana. Now, with that, David, I'm going to hand it over to you and to continue the discussion. Behavioral care, I love the connection that we're making today between the urine drug testing and prescription drugs and behavioral care. In my mind, the three have to go hand in hand. So, David?
Yeah, excuse me. Thank you so much, Phil. Good discussion this afternoon. You know, a few months ago, you saw the logo for the company that I work with, CareRisk, and I work on a clinical team as part of our care coordination efforts to help catastrophically injured workers and those also dealing with kind of delayed recovery issues around chronic pain and other issues. But for a couple of moments, I really want to speak to you from the place of my 30-year clinical experience that comes before when I came to CareRisk. Because as a trained addictions professional, as a grief recovery specialist, as somebody who has been trauma trained and worked for so many years dealing with patients, dealing with substance use issues, and even severe mental health challenges, I can tell you a large percentage of the patients that I encountered were patients that worked in, I think what we all are familiar with the term safety-sensitive positions. They were doctors and pilots and and nurses, but a lot of folks that worked in transportation. So I want to share with you a little bit kind of the view from the trenches when I sat with a lot of patients working in transportation to share the perspective that they shared with me and kind of shine a light on some of those behavioral health factors we begun to talk about a little bit. And before I do that, I want to go back to, about 45 minutes ago when we were talking about telehealth and maybe the opportunity now to leverage telehealth capabilities and maybe engage claimants, engage patients who've been hurt on the job a little bit differently. Just an interesting stat. I hadn't prepared to share it, but I think very timely and very relevant. Between January 1st and March 15th, we had about 15% of our patient population at CareRisk who chose for one reason or another not to use the mobile application that we offer, which is a downloadable smartphone application that allows them to chat with their care coordinator. It also allows them to be able to do the PHQ-9 patient health questionnaire so that we can screen for depression. We can deploy a generalized anxiety disorder screening instrument to them, and even a KJ to substance use disorder screening. But here's why I mention this before I get into some other information, is of all of those patients who chose not to use it for the first 3 months of the year, 75% decided to use it after March 15th, and over half of those injured workers work in the transportation industry. That really, I think, stands out and means something. So here are folks that, for one reason or another, said, thank you for the opportunity to be able to chat with my care coordinator. I choose not to do that. Thanks for the opportunity to be able to fill out a questionnaire about how I'm feeling or how I'm sleeping or things like that. I'm going to choose not to do that. They're really interested that they chose to use that smart application and be able to share information and stay meaningfully connected with their clinical care team, and obviously providing a lot of assistance to them through those means. So let me tell you a little bit about what I've heard from truck drivers in particular over many, many years. So one thing that's always been really telling to me, and one thing I've always admired and really appreciated about any patient that's courageous to share their experience, is what I've heard from folks working in the trucking industry that says, David, right off the bat, I feel like I'm at a disadvantage, and I'm not using some of the colorful language that I've often heard, but they'll talk about feeling at a disadvantage because they already feel less than. They feel less than because one of the first things they'll mention when they've sat in my office, and in an alcohol treatment program or when I was in private practice, I have a hard time dealing, David, with the fact that people see me as less than. Can't tell you how many times I heard long-haul truckers especially saying, people see me at a rest stop, or people see me, wherever they might encounter me, and they see me as being less than. Well, that's really resonated with me, because here we're talking about some challenges that I'll go a little more into. And just the default for a lot of folks that I've encountered working in transportation is to the extent that they're feeling going through depression, anxiety, maybe a substance misuse issue, that's usually on top of a lot of them already feeling, as I mentioned, and they put it to me, feeling less than. Let's talk about some other things that I've heard those folks in the transportation industry tell me about. I'm socially isolated. To the extent that I've got any meaningful connections with friends or family, I hardly ever talk to them. I hardly ever see them. I'm really, really stressed out, David. I've got, an excess workload and a really erratic schedule. And on top of that, as Larry talked about, I think wonderfully earlier, here I hardly get any sleep. Somebody who doesn't have the benefit of staying in close connection with their family. They're socially isolated from friends and members of the community that may have been a support to them. They work a lot of hours. They have this erratic schedule, maybe don't sleep very well. And so it's really no wonder, you don't have to be a mental health professional to kind of do the math here, that all of that stress and all of those extreme pressures really lead to a higher risk of behavioral health challenges, like grief, like depression, like anxiety, substance use disorders, right? That family disconnection, missing important events is something that I heard very, very often. I missed my child's baseball game. I missed all of my child's, ballet recitals for the better part of 6 months. So some of those things that may not seem like the most imperative kind of items to pay the most clinical attention to are really the things that I have heard about the most as a clinician from truckers especially. To go into some of the solutions that I have seen implemented by organizations to be able to benefit truckers, and heard truckers say about how much it has helped them. A couple things. First of all, having counseling available. And I know that sounds really simple, but having counseling available, and even having nowadays counseling available through, the means of telehealth. Leveraging social media. I learned more about some of the smartphone applications that truckers use, the vast majority of which I haven't heard of. Right, so there are smartphone applications like Viber. We've heard of WhatsApp, I think, but there's WeChat and ICQ. I think some of us know about Slack. There's also one called Talks. But I mention that because a lot of truckers have told me about the benefit of being on social media in a very positive way, especially where they can connect with messages that are supportive, motivational, that are helpful. Again, I've never heard any one of those patients say, well, that was the thing. But that, in combination with the availability of counseling, especially virtually, where they can benefit from that, has certainly been a help. Thirdly, so many people mention this to me, boy, I wish the Wi-Fi worked in my truck more often. Some things that maybe we don't think about. I wish the Wi-Fi worked in my truck more often, so I'm driving in a place I don't have, a good, reception on my cell phone, that I can access some of these resources. A number of folks that I've worked with in the transportation industry mentioned, I think it's called Trucker Ministries. And for those that are spiritually inclined, or those that really want to be able to practice their faith, albeit in some creative ways while they're out there on the road, those are things that have helped. So I really just wanted to share for a few minutes there some of those key things that I have learned from patients that I've worked with about how difficult it is for them when they're perceived as being less than, about how, with the weight of that, dealing with the social isolation, and the excessive, how all of those things, really affected them, and some of those solutions that I've learned from them. And here's the other thing, I don't think it'll come as a surprise to any of us, and it's been mentioned a bit, is the high incidence of stimulant use. And Phil, you were just talking about this a bit. You know, when we looked at a medication list of a lot of the truckers top of the list, Adderall, Ritalin, cocaine, methamphetamine, the vast majority of the time, which isn't to say that marijuana wasn't there, benzodiazepines. To your point, Phil, you know, we're not there, even if not always being properly used, but certainly atop the list there. So thanks for letting me share some of that clinical experience of mine working with folks in the transportation industry.
Well, thanks, David. Great perspectives, and I think we can return to some of that. Anne, you're going to bring us home before the panel discussion. I will share with the group that when I talked to Anne back in March, she said, "I can't talk to you, my hair's on fire." And we can see on the video right now that her hair is no longer on fire. So I'm glad that she was able to join us today.
First of all, thank all of the prior speakers. I was doing tick marks every time someone used the word telemedicine, telehealth, virtual care, and telerehab. And if I did my tick marks correctly, it crossed 30. So I think something happened this year in the world of care with telehealth. So I'm going to focus just speaking about what happened this year and as it relates to trucking, because very opportune time. I don't know who gets Joe Peduto's blogs, but he talked about telehealth and what it meant to the work comp industry today, and couldn't agree more with what he has said. It, you know, people thought something was going to happen with it when it first kind of really got on the scene, and learned a whole lot of lessons, including Anshner, about what it took to get something new and innovative going, and all understand it, get comfortable with it. But boy, COVID solved all of that really fast to be in that regard. What did Concentra experience this year? 500% increase from February to May in visits, just immediately soared. My term I give to it is suddenly everybody that was on the fence about it, was hesitating whether to put it in their program, suddenly wanted it immediately and wanted it like today, and for very good reasons. It has been a great solution during the pandemic. So the big question is, what's going to happen now? What did we learn from it? What are the current issues? And talk about still my thunder. One of the points I was going to say, I've tried to talk to, we have some national patients we have seen that are truck drivers and some of the challenges they face. And I know enough about truck driving and trucking to be dangerous. So please be patient with me. But apparently lots of them have company issued cell phones, but the company issued cell phone doesn't allow them to do the telemedicine software visit on that phone. So they have to either have their own phone and their own plan, and some of them are somewhat resistant to that. Interesting. I would have thought just use my own phone. Why is that what issue or problem for me? But that is one of their issues. The second one, we were just talking about Wi-Fi. Again, somebody stole my bullet point. Is they're out in a truck and they want to have a visit, and they're actually in an area where they don't have a Wi-Fi signal. And if anybody knows much about telemedicine and doing a virtual visit, a cellular signal is not the way to have the visit. Very rarely is that successful. You have to have a very strong signal in all bars, and it usually isn't a success. So those were the two main things that they said are barriers to doing telemedicine. And then the third thing, which also got mentioned, that was mentioned as a barrier to doing telemedicine, was post-accident drug testing. That comment was, if I have to go give a urine drug sample somewhere, why wouldn't I just have my visit there anyway? And that's where, thank you for talking about the oral fluid and how that can be used. And once again, not a product that personally have, but I've done a lot of due diligence on. That seems like there's a lot of opportunity in the future coming soon with that as well in that regard. Those were the three main themes that repeatedly came up. So if you can move on to my next slide. So you can see here, and this is from the trucking industry data, and because one of the things that often hear about with the trucking industry is there's not injuries that are appropriate for telemedicine, and so my drivers, it doesn't fit in with our program. And I always say, and when I'm talking about telemedicine, this is both for a new injury and then as part of the episode of care with a telemedicine visit. And as you can see, not all injuries are severe. And one of the great things about telemedicine is that the person can be seen rapidly. It can keep them in with the right level of care at the right place. And it can also take away their fears or concerns about that care, which is all extremely helpful. So somebody's injured at 2 in the morning and they twing their back and they're worried about what they should do. It keeps them from going to the wrong place for care. Also can explain to them, that what they're feeling is normal, what that recovery period is going to feel like, et cetera, and talk to them about all that, which has been great. So there's just so much going on in the world of telemedicine. Also, today I read an article. I subscribe to all the telemedicine news alerts or whatever, and there's so much going on. So all of the ambulance companies across the United States, I know of at least 4 that are all working on a program where they're using telehealth so that the EMT that picks up the person actually gets with a doctor and triages before they decide where they're heading with that patient to keep them out of the emergency department. Great outcomes regarding that. There's just a lot going on in this world of telehealth in that regard as far as care. So like I said, there's just so many great outcomes. One of the neat things that we've seen with truck drivers is the hours they work, the flexibility when they can have a visit, and the more likelihood that they can show up for the visit, not have missed appointments. It doesn't impact their work schedule because they don't have to drive somewhere and wait and to be seen somewhere, that they can do it easily. And then ones that are long haul, crossing state lines. I tell stories about where someone's had their first visit in California. They had their follow-up visit when they were in Utah and had their next visit when they were in Kansas. All great things with continuity and flexibility, and once again, making sure that their care is delivered in a great way. So if you'll turn to my next slide. So just some of the things I always talked about is the advantages of telemedicine, once again, for new injuries. As I said, if I was speaking to the trucking industry pre-COVID, I would get a lot of people saying, I don't know, and but like in most of the trucking companies that we have dealt with have all launched some sort of telemedicine. And one thing I always tell people, even if you don't think you have telemedicine in your program, run a report with who is ever doing your bill review managed care and look for the codes. And a lot of people have been extremely surprised by how many visits were happening out there that they were not aware of, because it's just a delivery care model that's been relatively new to the work comps arena, but is here, and we're going to see lots and lots of changes going on with that. So here's just the reasons, great reasons to why to use it, things that all of you have already said. And so I'm going to move on to my next slide. So what does 2021 look like, and what do we expect to happen? Because the big question is, when we have a vaccine and things go back to what we call normal, what's going to happen? Well, the good thing is that a lot of people tried it. A lot of medical providers figured out how to fit it into their practice, how to utilize the equipment, how to handle it or whatever. There are over 200 different software vendors hawking telemedicine software out there now. There's a lot of choices. There's software specific for psychiatric, specific behavioral health, telerehab, it goes on and on, home healthcare, nursing home solutions, kiosks, all kinds of things. There's a lot of choices out there. And the other thing that I talk to everybody about is bandwidth. So what kept telemedicine, even in 2020, always being successful is bandwidth. Either the provider didn't have enough bandwidth, or the patient didn't have enough bandwidth, or both, to create a successful visit. And bandwidth is coming fast and furious. There are tons of grants out there with rural access to care, with fiber going all across America. In fact, lots of times rural parts of America have better bandwidth than densely populated because of those solutions. But as bandwidth continues to improve across the United States, and almost everybody that works has a smartphone, there's just not many barriers to actually having those successful visits anymore. It's just going to be another part of the way care is delivered, and will continue to increase as you see that, as people get more comfortable with it. Both, like I said, both providers get comfortable with it and patients get comfortable with it, and it gets offered more and more as a solution in the care delivery. I liken it to, I feel different about going and sitting in a waiting room of my just general practitioner with other people who may or may not be sick, even after COVID's done. I don't know that I ever want to do that. It made me really rethink that. And all of those things are making people feel different about how care is delivered to them, and what is happening with that. So it's here for the long haul. What volume that will be, I would tell you, who knows, because there's so much development being done out there in the world of telemedicine. People still talk tremendously. COVID created a lot of buzz about peripherals and taking temperature checks and all those kind of things. And yes, there's lots and lots of work being done on peripherals and remote patient monitoring. There's lots of legislative work being done. 2020 was a very active year legislatively, with a lot of emergency regs and some permanent regs. That there was a lot of new legislation winding its way through the states for 2021 that's going to be heard. So there is a lot of activity going on with telemedicine, and a lot of neat things happening with it as well, with that access to care. Could talk about that. It's for the trucking industry, and specifically we talk about airlines, anyone that where are time sensitive and may be traveling in their job or whatever. It's just a great solution in that toolbox. So there we go, Dave.
Well, thank you very much. That was, and I'm glad that you were tallying the telemed mentions, because I was thinking about halfway through, gee, that would be a good idea. I should have done that. So thank you. Well, where to start? We'll have some questions from the audience, but I wanted to circle back, first of all, to one of the sleep issues that Larry Baird raised, and ask Tammy Reed and Lori, if your customers, do you think your customers are asking enough questions about sleep, or are they just focused on sleep apnea as risk managers? And you know, should they be doing more? I mean, I thought what Larry presented was pretty interesting, and it sounded like maybe there should be more questions being asked about that. Are they asking those questions? Because they seem to be pretty germane about the accident statistics. I thought that was pretty compelling stuff.
I don't see that they're asking questions about sleep. There is some with the DOT physicals that their sleep apnea comes up, but it's not regulated at this point yet, as far as I know, but not about general sleep. It's just not.
I think it's a little bit better than it was 10 years ago, but it's still not a major focus like it should be.
Mm-hmm.
Well, I'm sure Larry will be happy if your customers put him on speed dial.
Yes.
Yeah.
Maybe we should change sleep to the fifth vital sign. Just thinking.
Well, boy, there were a lot of unintended consequences from that one. So I'm going to mute your phone if you have any more suggestions like that. I don't know, Larry, you want to react to that at all?
Yeah, I mean, I think the comments are what I live every day. And transportation has its obvious uniquenesses because of the regulatory environment. And in 2016, the CME, the MRB within the FMCSA, their guidelines are mandated. And if those guidelines are followed on a consistent basis, a BMI and 3 more other conditions, our data will tell us that you're going to be at about 28% of the population with moderate severe that need it. Most people, just like you all said, we are getting a shift in transportation to more of a total well-being. And I think mental health has surfaced that, which I think necessarily gives a broader look at all of sleep. So our approach is let's manage the person's health, and those regulatory situations are going to take care of themselves. Yeah, which is not unlike we do in other employers without those safety sensitive roles. So it's evolving, but there's some that are still going straight at when flagged annually. What can you do for them? How quick can you get them back on the road and prove to us in the CME effective therapy? Yeah, but sleep's evolving. Yeah, absolutely.
As a primary care physician, I love the whole person focus. So one question for some of you who are handling claims and are risk managers, which would include Denise, Lori, Tammy, and your customers. I'm wondering, we haven't talked very much about the potential chronic effects of COVID-19, largely because we don't really know what they might be, but there is the potential for some real catastrophic, or what some might call nuclear claims there. I mean, we've seen some lung transplants from downstream COVID consequences, and all of the behavioral health and substance abuse issues that Phil and David and Dr. Stripp brought up, these also lead to the kinds of long-term psychosocial issues and substance abuse issues that also can blow up into some really big-time claims. So some thoughts about what are we doing to help keep, what are we doing to keep these things from blowing up? Or are we still just trying to keep the lights on and we have to start worrying about that a little bit down the line?
I think the long-term effects aren't truly being seen yet. Most of the claims, like I had mentioned, a lot of the claims are low dollar, lost a couple of weeks of work. We've had some death cases, but not a high volume. So I think everybody's still trying to sort through all of these long-term effects of COVID. And once we get there, but I'm not seeing most of the COVID claims. They're not staying open longer than 30 to 60 days unless they are a potential death claim. I just haven't seen that many of them where those effects are that severe. Has anybody else seen where they're complaining of long-term effects?
So my claims have not. We haven't seen the long-term effect, but we haven't been long-term either yet.
I'll take a little different spin on the question, David, and say what we're doing is trying to prevent that. So the initial triage of all of our cases includes education, like assessing any sort of comorbidities, because we know people with hypertension and other cardiac conditions are at a much higher risk of having severe, COVID cases, so more likely to be hospitalized. And so we do a lot of education initially with employees about that and prepare them and make sure that they're following up with their healthcare provider and continuing medicines that they're taking for hypertension or other comorbidides. Like the other two speakers, we have not seen large catastrophic losses as it relates to COVID, but I think, with the long tail line of workers' comp, that still remains to be seen if we want to see that.
So Richard Stripp, David Vittoria, how worried should we be about access to quality substance abuse treatment? Because it looks to me like it's declining.
Yeah, it certainly is. And I know it's coming back somewhat slowly, but I would say that we're probably and this is just an estimate, we're probably about at 70% of the capacity we were pre-COVID for that. So, it's certainly a realistic problem because, obviously when you're talking about substance use disorders, particularly like opiate use disorders and so forth, access to treatment is critical. And I think, a lot of those particular patients that were being treated, the likelihood that they may actually fall off the wagon, so to speak, or is very high.
Yeah. And I'll just add to that very briefly from three perspectives. First of all, my friends and colleagues that still work in the addiction treatment business, some of whom run either outpatient, partial day, residential, or inpatient drug and alcohol treatment programs, many of them have had to close their doors either because they had a COVID outbreak within the facility, or they had such a high number of their staff members, and not just the physicians or nurses who were frontline workers, maybe over in hospitals part-time, but they had a lot of their employees affected, family members passing away, things like that. One. Secondly, we've had about 12 claims referred to us over the last 3 months where patients, in addition to the motor vehicle accident or whatever the reason for the comp referral was, dealing with a substance use disorder issue. And we either had to get them into medication-assisted therapy because of their high-dose opioids, or we needed to get into a partial day treatment program, a residential program, less on the detox medical stabilization. But the second perspective is almost every single treatment center within our network that we reached out to get the patient, even without admitted, their schedules were compromised. They had far fewer slots for assessments and whatnot. Thirdly is the perspective that I hear from colleagues as a member of the American Society of Addiction Medicine and whatnot, that this is going on nationwide. I don't think that surprises any of us here. So I think that's having a real impact. And I think just one last point is it's leading to something that in my 30 years of experience in the addiction treatment world was already an issue, and is now it's more magnified, which is this idea that somebody with a substance use issue, it is an addict, right? And I think, as we all know, substance use disorders occur on a spectrum from mild to moderate to severe. But why is that even more poignant now? Because to the extent that that stigma existed, and there was this kind of blanket approach, put them in 28 days of rehab, this further limits our options, right? And so now you're not matching the patient to the right level of care that they need. So somebody who could benefit from a medication-assisted therapy program that cannot go in person to get their methadone dose and their individual counseling session, their psychiatry visit, that obviously has an impact. By the same token, if you can't get somebody into that 2 or 3 week residential treatment program, that clearly has an impact, perpetuates their use, and affects every other aspect of their life. Inpatient hospitalizations, at least based on people that I've known for a while, that hasn't changed much because in certain areas, I'm in South Florida, they've been able to get into medical stabilization into hospitals, but freestanding detox is very difficult.
Yes, and I would think that in some parts of the country, inpatient is probably not an option right now.
Yeah.
As well. Dr. Percelli, we've heard about all the wonderful things about telemedicine. I wonder from an OC physician's perspective, anything that you don't like about telemedicine that do we have some challenges that we still have to overcome from an occupational health perspective before we say that this is the most wonderful thing in the world?
Well, yeah, as Ann, had mentioned, it's certainly, those severe injuries are, more difficult to assess. In addition, I think there's still that component that, the older school kind of, drivers like a hands-on approach, so they want to be touched. That's often a complaint that I get with clinicians that are seeing patients that they didn't, touch me. So I think those are some of the limitations. But overall, it's just been a great asset, during this time. It's I don't know what we would have done without it.
Agree. Agree. Well, I want to turn this back to Dave Dubrow for a couple of closing remarks, but before I do that, I just want to say thank you all for your terrific participation and expertise, and I've learned a bunch of things as part of this, and I hope you have too, and I hope we all have a chance to continue the dialogue offline. So once again, thanks to MyMatrix. Dave, back to you.
Rachel, can you take me? All right. Thank you, Rachel. First of all, I want to thank the panelists as well. I found the information fascinating. I got the deck last night and did not peek ahead, but some of the metrics that came out of this were really interesting in terms of the 24% of injuries are related to insomnia, 24 work-related injuries, and Ann's 84.3% metric that could be treatable with telemedicine. And as you think about that and think about some of the other things, what are we doing on the prevention side? I just found it very interesting, and I appreciate everyone's participation. I also want to thank Mary Kay and Rachel for doing a lot of the orchestration and production in the back. You guys worked very hard to produce this day, and for once in 2020, besides a couple of web band issues, I think it went pretty well. And one last comment to the panelists. I'll be reaching out to you. I hope you all have a wonderful and safe holiday season. I'll reach out to you individually, hopefully before Christmas. And thanks again for your help.
Thank you.